Welcome you all to the live webinar conducted by Rainbow Children's Hospital. Today's speakers are Dr. Preetham Kumar Reddy, Consultant Pediatrician and Pediatric Intensivist, Rainbow Hospital, Vikrampuri, who will be speaking on the topic PPE during COVID-19, which, when and how long. And the second speaker is Dr. Parag Dekate, Consultant Pediatrician and Pediatric and Cardiac Critical Care Specialist, Rainbow Banjara Hills. He'll be speaking about the guidelines in management of COVID-19 in children. Do we have verdicts? Meanwhile, a request to the audience, while the talks are going on, you can type in and send your queries and doubts, and these will be addressed to towards the end of the session. I invite Preetham sir for the first talk.
Thank you, Surya. Good evening, all of you. And now we come to the hot topic now, which is COVID-19. And also, as doctors, we are always worried about what are we buying when it comes to PPE. So, initially, we are also confused as to what we should be buying. And there's so many things available in the market. So, we exactly don't know which works for what. So if you go to the market for N95, there are hundreds of them. So we exactly don't know what is the right one and whether it would suffice our purpose or not. So my talk now is going to talk in the next few minutes. I'm going to talk about the different types of PPE available and how are they different. So who should wear PPE? Basically, it's each one of us. So all of us who have contact with the patient have to wear this PPE, at least not the complete care though, but at least you should take some basic precautions to prevent yourself getting infected with COVID-19, because worldwide, a lot of healthcare workers who have been infected with this virus, in effect causing mortality also in few of these individuals. Now, coming to the transmission of COVID-19, first to understand which PPE suits us, we'll have to first understand how does COVID-19 get transmitted. Now, whenever we cough, we get out a lot of droplets. Now, these droplets are of different sizes. Any droplets which are more than 5 to 10 micrometers in diameter, they are referred to as respiratory droplets. And below that, they are called as a droplet nuclei. So that is the basic difference. And when it comes to airborne transmission, people would talk about, I think there are a lot of debate about what is this airborne transmission. Is COVID-19 airborne transmitted, or is it transmitted by droplets? So basically what it means is any less than 5 micrometer in diameter, it stays in the air for a longer time. So if you look at coronavirus, it has a size of almost it's 80 nm to 150 nm, so nanometers. So these are the particles. Once they get out of the infected body, they are floating in the air, and these particles, they don't follow a definitive path. That's the reason why we all need to be careful, because they don't follow a definite path. So not sure how they are floating. Like recent literature also says that, suppose initially they said when you go outdoor, the transmission risk is very less. But recent article says that if you're even outdoors, if the air speed is more than 4 kilometers, if it's less than 4 kilometers per hour, then the particle is there right in front of you. Whereas if the airspeed goes up to more than 15 kilometers per hour, then it's fine. So a lot of theories about it. Ultimately, we still have a lot of things to be learned also for this virus. So when you cough, so this is what happens. You cough, the larger spray droplets, they can go a little further away, up to 6 meters, but most of them drop down to the ground. Now what happens is, whenever these droplets are floating in the air, especially if it's a very humid environment, this virus, it gains moisture and then drops down. So that's how it drops down within few minutes to few hours. So majority of them would go down in 20 minutes, but it has been found that they have been airborne for almost 3 hours also. So again, depends on the environment, especially if your environment, you have a dry air and air conditioned indoors. Now, these are the high risk environments where it has been found to be present for few hours to sometimes a day also. Now, what is the size of COVID-19? As I said, this is what it is. It's roughly around 0.1 micrometer. And these are the different particles which we generally hear about when you look at reading newspapers talking about air pollution, PM10 and PM2.5. Now, these are something which are measured. You come in papers every day about the air quality. So these are different sizes of each of these particles. Now, if you look at coronavirus, it's at the extreme this side onto the left. You can see that 0.1 micrometers, whereas particles which are filtered by mass, they filter about 0.007. So technically, your mass should be able to filter out these coronaviruses. When it comes to the masks or respirators, there are three common types which we've already known by now. 3-ply masks, the N95s, the N99s, and other PAPR. PAPR is nothing but powered air purifying respirator. We'll come to that. Now, what is the purpose of a mask? The purpose is to primarily protect the nasal and oral mucosa from splashes and droplets of infectious material. And use of a fluid-resistant medical or surgical mask, which doesn't collapse against the mouth, is what is required. It should always be worn with appropriate eye protection, either with face shield or goggles. And if used with goggles, the mask should be fluid-resistant, because at least the face shield would make sure that whatever the splashes are there, they don't get onto the mask. So that's how it is important when you are wearing goggles to have a fluid resistant mask. When you are wearing a face shield, it's fine. And most of the times we keep hearing that people wearing 2 masks or 3 masks. Remember that wearing more than 1 mask at the same time does not provide additional protection, especially for 3-ply mask. Now we'll come to reuse of mask, then we'll talk about the other ones. But primarily, wearing more than 1 3-ply mask doesn't offer any additional protection and is not recommended. So now coming to the 3-ply mask standards, they should have a high fluid resistance, good breathability, internal external faces should be clearly identified, and important thing is structured design should not collapse against the mouth. We'll come to that why. We'll come to that in the next few slides. And
Preetham,
these
sir,
are the quality standards.
Preetham, sir, your PPT is not started, sir. Can you share your PPT?
Not started.
Sir. Sir. It started, sir. No. Yes, sir. Started.
Yeah. Sorry. So I'll start from here if you've not seen it before. Yeah, these are the different types of particles which are usually seen. Now it comes to PM10, it is a 10 micrometer, that's what it means. And it comes to coronavirus, the size is around 0.1 micrometers. Now respirators, as we all discussed, these are the standards for respirators. And this is the shape what we are talking about. So this is the shape it should be there so that it is not collapsible. So what happens is whenever in humid climates, the mass may become wet either through transpiration or whenever you are breathing or sweat. So that's how whatever the organisms on the exterior, they get carried over to the interior. That's why it is important that they should have a proper shape to the mask so that it doesn't wet your lips and you don't carry anything from the exterior to the interior. So that is what is important. Now, when it comes to a 3-ply mask, now there are 3 layers in it. That's how it is a 3-ply mask. There are 2 non-woven layers and 1 melt blown layer. So this is how. So this melt blown layer. Now, what is this melt blown layer? Melt blown layer is nothing but a plastic which is melted and blown onto a drum, and this is how it is woven into the layer, which is inserted in between these two non-woven layers. So the crisscrossing fibers of this plastic, they hold this particle. So that's how a 3-ply mask is definitely more effective than a 2-ply mask or a cloth mask. It always makes sense for even your people who are in the healthcare setting, probably not in direct contact with patients. They still would get benefited by using this 3-ply mask because of this reason. Now, how do you differentiate between a 3-ply mask and a 2-ply or a layer which has a melt blown layer and which it doesn't have a melt blown layer? Now, if you look at this two masks, the one on to the right, you can see it's a thicker layer which is a melt blown layer. So that's how you can differentiate between a mask which is a real 3-ply mask versus which is not a real 3-ply mask. When it comes to types of respirator, now, I'm sure all of us have heard about all these things: FFP1, FFP2, N95, and P3, N100. So these, how are they different? FFP1 primarily is European standard, and N95 is primarily a NIOSH. NIOSH is the American standard. So that's how they are different. And N means it is a non-oil proof, and it is again P is a oil proof, so that's how it is different. But for us, probably you don't need to learn all those things. What is important is FFP1 is like your it filters off 80% of these particles which are 0.3 microns in diameter or larger. That's how all the marks are graded based on this 0.3 micrometers in size. FFP2, it at least prevents out 94% of the particles. So it's equivalent to N95. In the context of COVID-19, so airborne transmission is possible, and always. Now, whenever you are doing anything like a aerosol generating procedure, especially like doing endotracheal intubation, bronchoscopy, suctioning, or nebulization, or using a manual ventilation, turning the patient onto one side, prone position, or any disconnecting the patient from ventilator for whatever reasons, all those things would cause aerosol generation, and always people who are around have to wear a N95 mask. No two thoughts about it. Now this is the uh, this is the size of particles which are usually uh, filtered out when you are using a N95 respirator. Now look at this. There are basically, whenever you coughing, okay, the most of these particles are somewhere around 1 micrometers in size, whereas all these N95, they have done a study where they found that they have tried 6 N95 respirators, and they could filter out most of the particles which are less than 0.1 in size, almost 95% of the time. So that's how it is a N95 respirator. So pretty much coronavirus is definitely filtered out when you wear this sort of a mask. What is important when you are wearing a N95 respirator is make sure to have a seal check, because the important thing is whenever you are wearing the mask, if you have a breakage in the seal, always there is a chance for the particles which are floating to get into your respiratory system or into your oral mucosa. So important to have a seal check. And how do you know whether you have a proper seal check or not? Once you wear the mask, whenever you are inhaling, the mask should go in, and whenever you are exhaling, the mask should come out. So that's how you know that the whatever the inhaling, exhaling is happening only through the mask and not through anywhere else. And if you walk briskly, you always would get breathless. Whenever you have a proper seal, you always get breathless whenever you walk fast. Now, what is a surgical N95? Again, the question is there are if you look at PM's catalogs, you would also talk about what is surgical N95 and medical N95 or occupational N95. The surgical N95 is nothing but where it is fluid resistant. So suppose you're doing a surgery and blood spills onto the mask. So surgical N95s do not let the blood get into the inner side. So that's how they are fluid resistant. So that's how it is. Nomenclature is surgical N95. Disadvantage of N95, it requires initial testing, fit testing definitely, and also periodic fit testing. And you have a facial hair always, it can cause an improper fit. And there's a poor tolerance by users due to breathing resistance and heat and moisture building up inside. And of course, there's a high cost to it, and also different types and sizes based on the people, and also potential for contamination due to exposed face and neck, because it only covers your mouth and nose. Again, people would ask, what is this valved N95 and non-valved N95? Which one should I buy? Valved respirators make it easier to exhale air, but again, it of course makes them more comfortable to wear and leads to less moisture buildup inside the respirator. But the problem with that is they do not filter the wearer's exhalation. So only the inhalation is filtered out. Suppose somebody is COVID positive and they are wearing this mask with an exhaled valve, then they are excreting out these, they're exhaling out these COVID particles into the air, and people who are around can get infected by these exhaled particles. So it's always important that people do not use valved respirators in medical practice. Again, if you have a valved respirator, one thing you can do is you can put a 3-ply mask over this valved N95. That would work fine. So that way the exhalation particles are filtered out. What is this PAPR? As I told you, it is a powered air purifying respirator. It is a battery powered blower that provides positive airflow through either a filter, cartridge, or canister connected to a hood or a facepiece. And different types of things are available. It has a HEPA filter, which has filtration almost close to 100%, almost filtering out 99.97% of particles which are less than 300 micrometers in nanometers in diameter. The pros and cons of HEPA filters of PAPRs, it is they have a greater level of respiratory protection than N95 masks. Advantage of providing hood and head and neck protection, because they cover most of your head. They do not require fit testing because of a full head, and it can be fine with facial hair also. Like somebody having a beard, it's still okay to use a PAPR. Disadvantages: difficulties in communicating due to their bulk and noise, and you cannot use a stethoscope with it, and you need to have battery or electricity to work on it. So important is either use a PAPR or a N95 when you are using in an aerosol generating procedure. And PAPR with full face covering or head shroud, it is should make accidental cell contamination during care difficult. So it's always better that you put a PAPR and over it you put a complete full face covering gown, so that it prevents you most of the times. So now these are few examples or few pictures of the different types. The PAPR, this is a partial one onto the right, and this one, the full one, which has even the face shield also. Onto the right one, there's a different set of goggles, not connected to the PAPR. Now, the question of N95. Now, when you go to the market, N95s are available for 300 rupees each piece most of the times, or most of the these days. Now, how do we rationalize their usage? And of course, availability also is a question mark. In this sort of a scenarios, how do we rationalize the usage and also decrease the cost? Something like extended use of N95 has been advocated, especially in this sort of a settings, in this pandemic situation by CDC. Now, what is this extended use? It is primarily suited to situations wherein multiple patients with same infectious disease diagnosis, like this pandemic where it is only the COVID-19 patient what we are dealing with. So there you can use an extended use of N95. The maximum recommended extended use period is 8 to 12 hours, definitely, and these should not be reused if the respirators are grossly contaminated with blood, respirator nasal secretions, and ideally they can use the healthcare provider can use a face shield or a face mask over the respirator to reduce or prevent contamination of the respirator. Now, extended usage and re-sterilization is one thing which has been going on. I think all of you might have gone through some literature about it. So what has been recommended is this, whatever the N95, the COVID-19 particles on a mask generally stay at room air for almost 72 hours. So what we do is give 5 masks to each individual, mark them as to 1, 2, 3, 4, 5, and then they can put it in a proper bag and use one each day and dry the rest of them whatever has been used. Suppose I use on a Monday I use one number mask. After I go home, or at the workplace I dry it properly so that the whatever you don't have to use any heat or anything, but you can dry it to air, and you can that mask after 72 hours is ready to use. So at least giving 5 masks to each individuals, so the it can be recycled that way, and each mask can be used for 5 users. So in effect, you are with 5 masks, you are able to manage for 25 days. So that the idea came from the fact that the COVID-19 expected survival time was 72 hours. Now, there was another study which was published which said that in some situations, COVID-19 was persisting more than 3 days, sometimes for 4 or 5 days, or sometimes for a week also. Now, how do we go about it, and how do we do a foolproof mechanism that what the COVID-19 is organism is not there on the mask what we are wearing? So next came the heat oven. So this is what we've been using. Now, hot air oven, especially for 70 degrees, 30 minutes would kill these organisms. So what we generally do at our place is we give 5 masks to the individual, and once on the 24th day or 25th day, we ask them to get the rest of the 4 masks, keep them in the oven for half an hour at 70 degrees, and all these after 5 days we ask them to get the already used mask, and we put all these 4 masks in the oven and then give them back. So this mask can be used for the next 4 or 5 days. So that's how we recycle these masks. And other options for sterilization of these masks are using hydrogen peroxide vapor. There is one company which is doing its Sterilist, but unfortunately, whatever the sterilizer costs around 30 lakhs, so probably not worthwhile in this sort of a situation. There is one Indian make which is doing the same job, but that also costs around 15 lakhs. So what is important whenever you are doing a reuse is make sure that the face seal is maintained. So that is what is the major problem whenever you do this hot air ovens. There is a little bit of disturbance in the fabric, so that's why you can develop a problem with the face seal. So that has to be taken care of. If you are finding that the face seal is not appropriate, please do not use it. You should have to go to taking out a new mask. So the standards for each of them, primarily is that the shape should not collapse easily and you should have a high filtration efficiency. And these are the standards, the NIOSH standards, or the European standards are EN 149, FFP2 or equivalent. This is interesting studies which I'm going to talk about in the next 2-3 slides. And we're trying to compare within COVID-19 size versus influenza size. Now, coronavirus, the SARS-CoV-2 is 0.06 to 0.14, and influenza is also roughly at the same size. Now, this is a study done on the influenza virus around 2011 time. Almost they had 2,862 healthcare personnel who were into two groups, one wearing N95 and the other wearing surgical mask. So in individuals who are wearing the N95, there were 207 lab confirmed influenza events, whereas compared to 193 in the mask wearing group. So a difference which was not statistically significant. In another study in Canada, Canadian nurses were split into two groups, one wearing N95 and those wearing surgical masks. There were 50 cases of influenza in the surgical mask group compared to 48 in the N95. So again, no significant difference. So now what happens when you wear a mask? No mask, the chances of infection are around 17%. Surgical mask probably around 5%, and N95 probably around 4%. But the important message is respirators are definitely the mask of choice. Surgical masks also offer some protection. Primarily, the idea of showing those two studies was not to it is primarily whenever you are exposed to some infection of a person who was N95 and you are not, who was COVID-19 and you are not wearing the respirator, at least the surgical mask also does some job, so don't have to worry. But that doesn't mean that you have to become very brave and then get rid of your N95s and start wearing surgical masks only. So that was the idea of presenting those two studies. Next comes goggles. Goggles, it is, you have to use these primarily to protect against eyes, mouth and nose, and on top of it you can use a face shield, but do not use a face shield and goggles together, as this does not offer additional protection but causes more discomfort and fogging affecting vision. Now when you look at goggles versus face shield, primarily most of them do the same job, and goggles with ventilation may have less fogging, but that is something which you need to look at buying. But other things are, there are some anti-fogging sprays also available, which can be used for healthcare workers who have prescription glasses. What is important is whenever you are removing the goggles or face shield, be vigilant so that you don't contaminate yourself while you are removing it. The summary is, it should have a good seal, skin of the face, and it should have a flexible frame that easily fits all face counters without too much of pressure. Face shield, again, it should be made of clear plastic. It should have a great visibility to both the wearer and the patient, and adjustable band to allow good fit around the head, and it should have a snug fit against the forehead, and preferably to have a fog resistant ones. These are the pictures of goggles, and this is the face shield what we use. The one onto the right, it's made by the Vega company. It costs around 300 rupees and is actually very good when it comes to fogging. It doesn't cost too much of fogging. Probably can be used for surgeons for operating. Gloves, use double gloves. Double gloves are always recommended over single gloves, primarily to decrease the potential risk of virus transmission from glove perforations. And it also reduces the risk from needle stick injuries. Sterile gloves are not required unless you are doing any sterile procedure like putting a central line or anything of that sort. Preferably, the outer glove should have a long cuff reaching well above the wrist, almost up to the mid forearm. And to protect the wrist area from contamination, the inner glove should be worn under the cuff of the gown, and outer glove should be worn over the cuff of the gown. So that's how you can prevent your wrist area from being contaminated. But do not attach these sort of a gowns or gloves to the gowns with any tape or anything, because when you are trying to remove the tape, you can again get contaminated. So that's how, please do not do it. Always disinfect for every step. You keep disinfecting for every after you wear gloves. To do any movements of you have to again follow the movements of hand hygiene, where you will have to, for touching the patient or touching your environment, anything, you will have to put the disinfectant on alcohol based hand rub and then keep disinfecting the gloves. If it's not possible to change gloves between patients, at least the outer pair of gloves should be disinfected between patients. Nitrile gloves are preferred over latex gloves because they resist chemicals, including certain disinfectants such as chlorine, hypochlorite, and nitrile is more environmentally friendly than latex, but of course more costly. It is 3 times that of latex. And there are some allergies to latex. That's how the nitrile does prevent that. Now coming to the complete protection, the equipment, it should be either a disposable gown or apron, and the gown should be made of a fabric that has been tested for resistance to penetration by blood and other body fluids. So surgical scrubs may be worn under the protective clothing, and these are considered as regular on-duty wear and not as PPEs. A disposable gown to almost, it says it should be a single use one coming up to mid calf length to cover the top of the boots, and prefer light colors to allow better detection of any possible contamination. Thumb or finger loops are beneficial in case you get it. And we talk about GSM when it comes to PPE, it should be 70 GSM and above. Footwear, ideally you should have a non-slip one with a PVC sole that is completely sealed, and it can be up till knee high. Or you can use there are other foot covers also which can be used over your normal footwear. Head cover, the purpose is to protect the skin and hair of the head and neck from virus contamination and the possibility of subsequent virus transmission to the mucosa of the eyes, nose and mouth. So important is to cover your mucosa of the eyes, nose and mouth, because these are the portals of entry of these viruses into your body. And try to fit the hair and hair extensions mainly for ladies, so that it should be inside the head cover. This is the different types of head covers which are there. And this is the personal protection equipment what we have, and it contains all these things: the head cover, the foot cover, your mask, gloves, goggles. So these are the ones which are available. Now this one previously was sold for almost 1,000 rupees. Now I think it is being sold for 400, 500. So points to remember while using PPE: they're not alternative to basic preventive public health measures such as hand hygiene, respiratory etiquettes, which must be followed at all times. Always maintain a distance of at least 1 meter from suspects. Always follow the laid down protocol for disposing of PPEs, like doffing and donning definitely has to be respected. So these are anyway available. So you can put on these things in a specific order. The primary thing is to the reason for this order is to not to get contaminated while removing it. So that's what is important. And this is another thing what looking at, having an intubation box for intubating these babies or children who come with COVID-19. Now this is to decrease the spread, because this is one of the aerosol generating procedures, especially when you're trying to intubate somebody and they cough, the particles are all around. I think there's been a good video in NEJM which showed that once you cough, I mean the particles were also on the roof of the room. So that powerful dispersion of particles. So this is the size of this particular intubation box. we are using currently, which is made from one of our doctor's husband, who's and this advantage is it's almost a size of a pentagon, where you can the assistants also have good access to patient, and there are different ports, and these ports, if you look at it, are covered with a plastic cover, so that if they are not in use, they can be covered, so that the patient is, whatever the secretions of the patients cannot get out of all the openings. To sanitizer, this can be tried. There's a Bacillol 25 available. You can, especially when you're coming home, you can use it onto your soles to disinfect your shoes. So these, lastly, we coming to the areas, basically from the Ministry of Health and Family Welfare's website. So these are the areas where you need the recommended PPE, a triage area, N95 and gloves, screening area again N95 and gloves, doctor's chamber also N95 and gloves, sanitary staff also N95 and gloves, visitors and others, they're low risk, basically they can manage with triple layer medical mask. Inpatient services, isolation rooms N95, and ICU and critical areas, always a full complement of PPE. And if there is any low risk area where you're not admitting any respiratory, probably a triple layer mask is fine. But if you're admitting any COVID-19 patient, then it's a full complement of PPE. Thank you.
I request Dr. Parag Dekate for the next talk. Meanwhile, audience can type in the questions.
You're able to see my presentation?
Yes, sir. You can
My
start.
presentation is visible?
Yes, a wide screen I'm able to see. Can you go to next slide?
No. Now it is visible.
Yes, sir. Yes,
Okay.
sir.
Good. Good evening, everyone. After a nice talk by Dr. Preetham about personal protective equipments, I got a task to deal with the guidelines. And everybody knows at this moment we are flooding with a lot of knowledge related to the guidelines as well as how to manage these kids. So I did kind of a review where actually I tried to segregate them. How it's a famous meme at this moment which is going through internet, and we could see there are so many guidelines we have, and most of these guidelines related to the adults, and we are trying to navigate through all these guidelines to identify whether we can actually fit these guidelines into the pediatric population. And the one thing I wanted to tell you, whatever I have read in the last few weeks, only one thing I realized: more I read, more I'm getting confused. And there is a lot of, I would say, things going on at this moment, like how to go ahead and treat these patients. Though there are few things which are very very clear related to the management of these children. So uh, today's topic, I wanted to go through this presentation in two ways. One is uh, what we know, because guidelines is about what we know, and what is not clarified, because we wanted to come to some conclusion. So what is the general understanding about the disease, pathophysiology, which is very very clear, so we know about it. What is the pathophysiological mechanism in ARDS and sepsis, thromboembolism, TIC, is secondary infections are common in them, or they are causing any concern. Immune dysregulation. We had a nice talk by Dr. Farhan as well as Dr. Nageshwara about immune dysregulation. Other being supportive management, which is quite standardized. But there are few things which need to be clarification, or they are not, I would say, clarified or verdicted that we can use this. These are antivirals, medications, IVIG, plasma therapy. There are a lot of things going on around monoclonal antibodies, prophylaxis, whether pre or post-exposure prophylaxis, which has been really debated in the last 1 week, or you can see in the television. Vaccines, and what about immunity and reinfection? So I try to club all those things together, and let's go through this. So this is a basic of my presentation. So what do we have, clarity or verdict? So do we have a clarity? So yes, there are a few things which are very clear. So if you say what we know about the management, definitely we are very clear about the pathophysiology, physiological basis of lung injury and immune dysregulation. We are trying this. This is more related to the pediatric population. What other things we know? Treatment modalities available. What are the treatment modalities available related to the COVID? So it can be non-ventilatory, supportive, ventilation. What are the guidelines related to the septic, sepsis and septic shock, secondary infections, immunomodulatory effect of medications, and other organ support, which is pretty standardized with respect to the organ dysfunction. What other thing is, we are very clear what Dr. Preetham has told about personal protective equipments and patient segregation. So I'm going to touch a little bit about it also. But what we don't know, there are few hypotheses related to the less infectivity in children, few related to the adaptive immunity, angiotensin converting enzyme 2 receptors, which are there in the nasal epithelium, and the kids see less morbidity. So that could be one of the reasons. Therapeutic agents, there are multiple things debated all over the literature since last 3-4 months, which is hydroxychloroquine, ritonavir, lopinavir, and other antivirals. Blood products or blood-related products, what you can say, IVIG and plasma therapy, which has been investigated at this moment, and other things which needs clarification. One of them is vaccine. What about the recurrence of COVID-19? Because we have started seeing some case reports from the China that they're getting a reinfection. What about immunity post-infection, and when things will be controlled? So let's go through each and everything. So what is our general understanding about pediatric or children involvement in the COVID? So it's basically a difference between the two. And if you see, we can see about involvement of the pediatric population, and what we have gathered all over the world, that we are seeing a less severity of the patient. The infection rate are little bit less. If you see, in the United States of America, only 1.7% of the patients are less than 18 years of age, and they are requiring less escalation of respiratory support. And few of the hypotheses given, because the pediatrics are less involved, is the less expression of ACE2 receptors on the nasal epithelium, which is a point of entry of COVID, adaptive immunity related to the BCG, and less comorbidities. But if you see, 4 to 6% of the children with the SARI, severe acute respiratory infections, are positive for COVID. So we have a very good chunk of patients which are actually negative. And I just wanted to tell you, whatever the patient at this moment we are admitting in our unit, most, actually all of them are negative except few. So only 5.7% of the above patient required hospitalization, and 73% of 1.7% had a respiratory symptoms. So this is a severity classification given by National Institute of Health, CDC, as well as IDSA. You can see the level of sickness ranges from asymptomatic, mild illness, moderate illness, severe illness, and critical illness. And they have tried to objectively make them classified depending upon the clinical features. So definitely you need PCR positivity. And asymptomatic patient, the other things are not there, no saturation problem, no clinical features, and everything is fine. Mild illness, mainly they don't have a work of breathing but upper respiratory tract symptoms, and the lung infiltrates are absent if you do a chest X-ray. Moderate illness, you have LRTS symptoms, saturation is well maintained in the room air, and the lung infiltrates would be there. Once you go on, the lung infiltrates increases. It is increasing more than 50% of the lung field. PF ratio is going down, as well as the room air saturation. And then we have a critical phase, what we try to call off, and we have a very good pathophysiological mechanism for that. It's basically a cytokine storm or probably a multi-organ dysfunction. And this risk stratification is based upon clinical features, saturation, lung infiltrates, and PF ratio, which is given by the NIH. So a short word about risk stratification and disposition. We do know that, but one thing, make it sure that the confirmed patients are not being mixed with the suspected and probable. There are pretty standard definition given by the WHO related to suspected and probable. So we have a severity of the illness. Most of this patient require a separate isolation ward, preferably negative pressure isolation ward. And if you're dealing with the moderately or critical patients, definitely they need to be taken care in the isolation room with the negative pressure ventilation, preferably with all protective personal protective equipments has to be taken care by the healthcare personnel. So what are the high risk factor in the pediatric population? All of these things have been very well studied. What they have seen it, we know about adults that hypertension, renal disease, cancer, obesity, and diabetes are very high risk feature for the having a serious outcome into the related to the COVID patient. What they have said is same thing if it is present in the pediatric population, that is also a high risk features. Other things being underlying congenital heart disease, severe malnutrition, immunocompromised state, which propensate them to have a severity of severe disease. What are the risk factors for the severe disease? How do we identify early if we try to see these risk factors? So those are having some work of breathing or dyspnea, tachypnea, high spiking fever. They have a chest imaging findings, low multilobar involvement, pleural effusion, smaller age group, extrapulmonary manifestation in the form of a rash or features of a shock, and co-infections, as well as cardiac and liver enzyme elevation. These are all features suggestive of a severe disease, and probably they are going from the severe illness to the critical illness. This is a pattern of progression which we have seen all over the world. What is happening is initial phase, they have, most of them are mild, few of them are common, and very small chunk, probably around 15 to 16% in the adult population are severe or critical. And few of them has improved. And if you see, a lot of them has deteriorated, which required oscillation and hospitalization. And when they landed into the ICU, most of them died because of the bad ARDS. But those who had a mild and common, most of them had the pathway towards the recovery. So as we know that we are very clear, and we are getting more and more clear related to the pathophysiology of COVID. And we know that it involves lungs, heart, it has an effect on the immune regulation, multi-organ dysfunction, and some hematological. So we are going to dissect each of them. So what is this? So we know about this virus, and there are multiple proteins all around which is causing. And one thing which we are very well versed with, the S protein, because this is one which binds and makes the virus go inside the cell. And we know that it's a single fragmented RNA virus, and which has been related. This RNA has been related to a lot of utilization of our antivirals. So if you see that after this RNA virus comes into the body, we have some kind of a cytokine storm, and you see a lot of cytokines has been released, interleukin 6, 1, 10, 7. So they are causing a lot of issues. And if you see pulmonary endothelial injury, epithelial injury, T cell adaptive immunity, as well as humoral immunity, and having a multi-organ dysfunction related to the apoptosis of the cell as well as cytokine storm. This is a nice schematic representation. If you see, there are multiple ways you can get a coronavirus inside your body through the respiratory tract. Itself causes a lot of inflammation into the lung alveoli, which releases a lot of inflammatory mediators, interleukin 1, 6, tumor necrosis factor, which causes, like we know that it stimulates the hypothalamus, causes fever, and which itself causes increasing increasing DO2. And alveolar edema itself related to the vasoplagia, as well as cytokines are related to the vasoplagia. Then we have an infiltrates, which itself causes tachypnea, and then we have a difficulty in breathing. And this is an intracellular mechanism which is related to the amplification of coronavirus. We'll come to that. Other being the myocardium, which we are seeing since last probably 6 weeks. We are seeing a lot of kids having a myocardial dysfunction or probably a myocarditis. So same mechanism, there's a lot of cytokine release, interleukin 6, 7, 22. And what they are doing is they are actually directly damaging the myocardium, which makes them susceptible for fulminant myocarditis, increase in the cardiac enzymes. Then they can have a higher chances of arrhythmias and a very bad function. And at the same point of time, the primary endothelial injury, which is actually responsible for coronary artery disease in adult as well as pulmonary thromboembolism. And there is a lot of mechanism in the form of lupus anticoagulation has been suggested in pulmonary thromboembolism. And this mechanism is also important for thromboembolism in the pediatric population also. So talking about a lung injury, as we saw that it goes inside your body through the AC2 receptors and causes inflammation. So depending upon the level of inflammation and the pathophysiology involved, so the lung types which are a product of an inflammation has been typed into L-type lung. They have a vasoplasia. This is a pathophysiology related to that. H-type lung and pulmonary thromboembolism. Let's talk about it. So what they have found, Gattinoni, that there are two types of lung we see in a lung involvement in COVID. So early phase, they're compliant lung. They look like a normal kind of a lung. And if you bag them, and if you intubate them, you'll see, oh, lungs are really, really easy to bag. So what they have found in most of them through the CT scan as well as their autopsy is most of the time is a subpleural pathology. They have a significant vasoplasia. So if you see the membrane, which actually responsible for gases exchange, is being damaged from the, I would say, blood point of view rather than the air point of view. So most of them had a good compliance, okay, and there is a low recruitability. So there is no fun of giving them a high PEEP. Low VQ mismatch is there, and they have a silent hypoxia. There was one picture which was going into the literature that a girl who's having a saturation of 60 and playing on the mobile game. So it is a silent hypoxia, and this made a lot of people in United States of America as well as Europe. It is standard practice to give a oxygen meter to them to monitor their hypoxia, and if the saturation goes less than 93, they ask them to come to the hospital. And in the New York, what they did, even if the saturation is less than 93, they asked them to take oxygen at home, unless and otherwise they have a significant work of breathing. So they are basically low volume lungs. Let's come to the late phase of non-compliant lung, which we see as an H-type lung, which is like our ARDS lung, which is very, very bad. So there is a generalized pathophysiology, there is an alveolar edema, inflammation, they had a bad compliance, there is a variable recruitability depending upon the etiology, high VQ mismatch, and they have clinical hypoxemia based upon the lung involvement. So pretty standardized. But what respiratory intervention we should do, how we should manage, there are few things which are required before ventilation. So remember, there is no emergency, don't rush to this patient, take all precautions before jumping onto the patient. Avoid bagging. If you feel the child is going into the respiratory failure, it is better to use 2% technique for bagging if unavoidable, because it will increase the seal of a mask and decrease the aerosolization. Use HEPA filters while bagging to connect between the mask as well as bag, and use Bain circuit, because with the Bain circuit you will be a little bit far away from the patient. At least you'll be able to maintain a distance of 1 meter. Try to good sedation and use judiciously muscle relaxation. Transparent box as shown by Dr. Preetham, which can be used to decrease the exposure to the aerosols. Clamp the ET tube and attach to the circuit, and use HEPA filters while attaching the ventilatory tubings to the ET tube. So what about the actual ARDS management? So I told there is a lot of literature related to the adults. What Gattinoni suggested for the early phase compliant lung is we can try HFNC. So at this moment, there are no guidelines in the pediatric. They're saying don't use HFNC. What they are saying is use usual protocol for escalation of the respiratory support in the pediatric patient. So you can use HFNC and NIV, but remember the limitation of a flow to prevent aerosolization of these COVID particles. Remember, they are non-recruitable lungs, so use generous oxygen, maintain the oxygenation, and if intubate, require low PEEP. Most of the time, as I told you, they are non-recruitable lungs, and probably they will require high tidal volume. Early proning is better in this kind of a patient, and avoid spontaneous rapid breathing in this patient to avoid spontaneous lung injury related to the spontaneous breathing. What about the late phase? You can use lung protective ventilation in the form of high PEEP, low tidal volume. Keep your driving pressure less than 15, plateau pressure less than 28. You can use deep sedation, optimize FiO2, and you can judiciously use your skeletal muscle relaxant. And proning and INO can be tried in a desperate situation where you are not able to improve the oxygenation. Remember one thing, Lot of this patient in the early phase who had vasoplagia and some pulmonary thromboembolism related to the adults, they are not getting benefited with the ventilation, all the strategies, and they are straight away going on the extracorporeal membrane oxygenation because there is no way we can improve their pathophysiology related to the oxygenation. Coming to the hematological and thromboembolism, uh, so the American Society has recently, like a week back, has released these guidelines. What is the pathophysiological mechanism of thrombus formation and what are the transfusion threshold in this patient? Because it's a common thing we see because we have a lot of patients with the hypoxemia, whether to transfuse or not. You see, there is a lot of immune complex deposition in this pathophysiology, and there is a tissue inflammation, pro-inflammatory cytokines, and the cytokines released through the macrophages, natural killer cell, and neutrophils, which itself causes tissue inflammation and damage. And endothelial injury related to the blood vessel, which can be myocardial blood vessel, lung blood vessel, it promotes thrombus formation. So how to differentiate? Because we see a lot of 20 to 30% are coming with the sepsis or bacterial infection. So how do you want to differentiate between the two? So they have given rightly how to differentiate softly between the two, which is thromboembolism related to the COVID and sepsis. So you will see marked elevation of fibrinogen and D-dimers in sepsis-related thromboembolism. While in COVID, there will be elevation of fibrinogen and D-dimer, but not markedly. They have a high CRP, ferritin, and most of the time low PCT if the organ damage is not set in. Because remember, PCT is because of the release of eukaryotic mitochondria into your circulation, and you are also a eukaryotic organism. So any cell lies in your body, the PCT will go up. But most of the sepsis are bacterial, so you will see relatively low CRP because it is not hyper-inflammatory. Unless and otherwise you are going into the cytokine storm related to the sepsis, you have a relatively okay ferritin and high PCT. They have most of the time mild some thrombocytopenia, while sepsis have a very high, means like low levels of platelets, minimal rise in a PT APTT. They have a prolonged rise in the PT APTT and IRR. Full-blown DIC will be rare because most of the time it is a targeted coagulation problem, while in here it is related to the multi-organ dysfunction. You will see a lot of lupus-like inhibitors in COVID-related thromboembolism, which is less likely in sepsis. And they both carry high mortality and may or may not be related to the cytokine storm in a sepsis, but most of them in thromboembolism related to COVID related to the bad ARDS and cytokine storm. So what are the transfusion threshold related to them? So what the American Society of Hematology has said, these are all adult guidelines because there are no pediatric. Only if actively bleeding, remember, because you are dealing with a procoagulant state. So giving blood product is adding actually fuel to the fire. So if platelets are less than 50,000, INR more than 1.8, fibrinogen less than 1.5, they suggest supplementing the blood products. And they have strongly question the efficacy of tranexamic acid if the child is bleeding or a patient is bleeding. What about sepsis and septic shock management in COVID? So we remember the secondary infections are pretty common here, and we don't need a separate guideline for sepsis and septic shock, but I'll touch based upon the management things. So what we got, this is an article published in the journal Pediatrics. 15 to 20% Chinese pediatric population had a secondary infection, and our previous experience with H1N1 also tells that the chances of infection is 1/3. Mainly those who had a severe disease had a higher chance of infection because of the higher invasive therapy. They are more sicker and they are more likely to die. And we should consider appropriate community-acquired antibiotics or bugs. If you have a high PCT, child is presenting shock, multi-organ dysfunction, or having a invasive therapy. So be early to start antibiotics. You have all these features. What about sepsis and septic shock? So surviving sepsis guidelines, which recently came in May 2020, they have said they have used same definitions, same protocol as a normal sepsis in COVID patients, but they have raised a suspicion about keep it in mind cardiac dysfunction and PIMS, which is actually a pediatric multi-organ because of the inflammatory storm, and while giving a fluid policy. So keep in mind about the cardiac dysfunction and myocarditis. They have said co-infections are common, so think about it. In adults, they have said azithromycin and doxycycline upfront to use as an immunomodulator as an atypical coverage. Other infection-specific antibiotics to be used, organ support as needed depending upon the CRRT or ECMO if the hemodynamic parameters set in, and ventilation, the standard ventilation strategies if you have a secondary respiratory involvement, and if it is a primary respiratory involvement, we have touched based upon the L and H type of the lung. So this is an algorithm given by them that if you have, which is pretty standard related to the where you have a resourceful setting or a non-resourceful setting with hypotension, without hypotension. You can try 40 to 60 ml per kilo if you are in the ICU setting. If you are not in the ICU setting with hypotension, then only fluid bolus up to 40 ml per kilo, not more than that. But if you don't have hypotension, don't give fluid bolus, start maintenance fluids. And any point of time, any feature suggests you have fluid overload, then probably stop fluid boluses and start inotropes immediately. Now, what about cytokine storm and a vasculitis? So, different pathophysiological mechanism. This is an article which is actually came online, but they have written a date of June 2020 for publishing, and very, very important things they have pointed out. So I will tell in short because I don't feel so I should go into detail. So this is a nasal epithelial cell, okay? This virus comes inside. Remember, when the SARS COVID virus comes inside the nasal epithelial cell, the outproduct is the inflammation will not be that much. If you see most of this patient, they don't have an epithelial inflammation. Most of them don't have a nasal congestion. All those things are not there because of the interferon, the dysregulation of an interferon and some factors which causes decreased inflammation, local inflammation, which promotes the entry of COVID virus into the nasal epithelial cells. Because we are seeing a two spectrum. We are seeing a spectrum where there is a cytokine storm and high inflammation, but at the local level there is a less inflammation and down regulation of interleukin 1 and interleukin 6 and tumor necrosis factor alpha. But at the same point, when they go into the macrophages or probably our cells, the scavenger cells, so what happens? There is an upregulation of interleukin 1, 6 and tumor necrosis factor alpha. So the virus is having two different mechanisms at two different sites. So really a scary thing that they are paralyzing your local mechanism and they are increasing your cytokine release. Same thing we have said, lot of tissue damage and lot of polymorph involvement. And one thing, we have a direct involvement of the organ or indirect effect because of the cytokine storm. So what happens, how we say and how we got to know, and remember, even before we had this cytokine storm, we have seen a lot of adults having a multi-organ involvement. So how it happened, we started having COVID, ARDS, then multi-organ dysfunction, and then we started thinking about cytokine storm. So you see, a lot of these adult patients have a multi-organ involvement, and the mortality is pretty high, ranges from 16 to 61%. And a lot of them required assisted therapy in the form of ventilation, inotrope, CRRT, ECMO. If you see the pediatric, the ICU rate is, as we said, 2 to 3% of the pediatric patients go to the ICU, and mortality is a little bit low as compared to the adult population. What is this cytokine storm or PIMS? So what WHO said, age, definitely pediatric, less than 19 years of age, and had fever more than 3 days, and two of the following, which is rash, which can involve the body rash, you can have a mucocutaneous involvement, you can have a limb edema, then you should have a hypotensive shock, myocardial dysfunction, coagulopathy, and GI dysfunction. Two of these 5 things should be there. Other elevated markers of inflammation in the form of CRP, PCT, ASR should be no obvious bacterial cause for this. So it should be an isolated identity. And the frequent mimickers related to this is toxic shock syndrome, Kawasaki disease, and a sepsis. And definitely, a lot of teaching from the West has taught us that most of them had a late presentation. So they present after 2 weeks. So most of them have a negative nasopharyngeal swab and their antibody test is positive. So what are the specific therapeutic modalities for them? So definitely we need to support the organ if they are failing in the form of inotropes, ventilation, and other things. But non-critical patients, what we required is they have tried is IVIG 1 to 2 grams per kilo. Definitely if they have a KD-like presentation, high dose aspirin, and they have suggested if you have a KD-like presentation of vasculitis, and few of them has tried methylprednisolone empirically in this patient. But if you have a critical patients, so definitely you can still try this, but there are few other things they have suggested in the form of tocilizumab. We'll come to that in the later slides. Anakindra, again tried, but without any positive benefits. Interferons, because if you see the inflammation, what the slide, previous slide, everything related to interferons. There is an imbalance of interferons which transcribe the signal at the local level and the systemic level. And other extracorporeal therapies, if you landed up in a scenario where you are having a multi-organ dysfunction, cytosol, which is a cytokine removal tool. What we know about personal protection, really, Dr. Preetham has covered it really well, and we should follow that very stringently. Supportive management, very clear. So we try minimal nebulization, maintain the fluid balance, nutrition, minimal handling, minimal chest X-ray to avoid health exposure, and other organ support, as we discussed. Might require central line, arterial line, CRRT, infection control, which remain pretty standard with sedation and analgesia also. So let's coming to the main thing which is actually confusing us, that is specific drugs used in COVID. So this is a very good article given by James Sanders in a form published in a JAMA. Very good article. If you see, there are few targets of medication. So this is S2 receptors where the COVID virus is entering into the nasal epithelium. So if you block them, probably will block the entry. Second thing is this chemostat mesylate. So there is another receptor which is responsible for engulfing this inside the cell. So this is tempress receptor which can inhibited by the chemostat. Then you have arbidol, which has also been tried with lopinavir and ritonavir. If you see, it prevents the binding of S protein to this AC2 receptor. Then we have a diamond in the crown, which is a chloroquine. So what it does, it prevents the endocytosis or engulfing of this virus into the cell. Then we have another thing, lopinavir or ritonavir, which inhibits the polypeptide generation. So then we have next ribavirin, remdesivir, which is looking a little bit promising to the current literature. So it inhibits the RNA polymerase. And then we have this experimental therapy or a salvage therapy, tocilizumab and sarilizumab, which actually an antibody which binds to the IL-6 receptors and decreases the cytokine storm. So let's go through it very slowly. So up till now, if you go onto the registry, you will see almost there are 300 clinical trials related to the treatment. And out of them, 109 are pharmacological therapy. Out of them, 82 are interventional. That means they're either going into placebo or interventional arm. 29 are placebo controlled. So there are 82 interventions actively going. Out of them, 11 are phase 4. That means almost they are completing. 36 are phase 3. So there is a good amount of progress related to the interventional trial or a pharmacological therapy in a COVID. So what are the antivirals we use? Are we hitting in the dark or are we hitting in the target? We don't know. So these are the few promising medications which we have actually seen through the literature. Let's go through each and every one. So let's talk about ritonavir and lopinavir. So we know that this medication is an anti-HIV medications, and there are limited available studies of ritonavir and lopinavir in COVID. But it was a little bit promising in severe acute respiratory syndrome, which was happened previously, that it has reduced a little bit of mortality and reduced the intubation rate. But mind it, most of the studies actually use the ritonavir and lopinavir early. So you have to really give this medication early in the peak of viral replication, because if you give them late, we've already missed the boat. So the target being 7 to 10 days, there is no definitive data related to that. And delayed therapy, they have specifically said there is no effect because you are giving the medication when the damage is already done. And this is one of the arm of a solidarity trial, which will come to that, which is alone as in ritonavir and lopinavir and with interferons. Let's talk about this. Is an article published on May. So what they have, it's an adult randomized control trial. 199 patient has been randomized, and what we said, average day when they got this randomization is 13 days, so pretty late. So I don't know whether we can draw a conclusion related to that. So it was placebo and those medications. There are no mortality and morbidity benefits, no early viral reduction you can see. So this is cumulative improvements. So not much of a difference. At the same time, viral load, not much of a difference. So ultimately, it has not won the test of time. Another medication, remdesivir, which is actually looking a little bit promising, and there is a lot of preliminary report and early data coming through the NEGM. So we know that it affects the its RNA dependent RNA polymerase inhibitor. And we have a lot of basically this medications came from Ebola. So they have extensively studied this medication 2014 about Ebola virus. So it's a broad spectrum and a potent medication, and it is not approved by FDA for kids less than 18 years and a pregnant woman. So we have to be very, very clear related to that, whether we can apply this to the pediatric population. And again, this is one of the arm of a solidarity trial, which we'll discuss in the next slide. So what happened? This was double-blind, randomized, placebo-controlled interventional trial. Most of the patients with the lower respiratory tract infection adults, what they did, they give 200 milligram loading dose on a day 1, and then 100 milligram daily for the 9 days. And the primary outcome was seen as a time of recovery. And the patient randomized were pretty good, 1,000 patients, around more than 1,000 patients. What happened? What they found? So overall, a little bit better. Yes, a little bit better as compared to overall performance of remdesivir, and at the same point of time, little bit improvement in the oxygenation or less requirement of oxygenation. And ultimately, what they found, initiation of ventilation and ECMO is also a little bit less in remdesivir as compared to placebo. So what they have concluded is definitely remdesivir was superior to placebo in shortening the time of recovery in adults, those who had a hospitalized and had a lower respiratory tract infection. So little bit promising related to the recovery of inpatient, and less initiation of ECMO, less ventilation and less oxygen utilization, but it was not statistically significant. Let's come to another medication, because ribavirin is one thing which is available, whether we can use it. So these are the two extensively studied research which has actually studied ribavirin and favipiravir. So again, both of them are inhibits RNA polymerase. Ribavirin, most of them we use in the RSV. So activity against COVID is limited, so we won't start them as such like that. Requires very high concentrations, so very high doses and high levels of toxicity, and had a high hematological and liver toxicity. Favipiravir, if you see, it goes hand in hand with remdesivir. So again, broad spectrum, requires very, very high doses. If you see the doses, they are ranges from 3,000 milligrams to 2,400 milligrams. There was one short RCT, which was, this is Chinese RCT, which was published in the March, about favipiravir and arbidol. So favipiravir, RNA polymerase. Arbidol, if you remember, it prevents the binding of this COVID virus to the ACE receptors. So they said there is a little bit of early recovery in favipiravir in moderate infection, but if you consider mild, moderate and severe infection, there is no combined benefits, and they said you requires more RCT to know the beneficial effect of favipiravir. Now again, diamond in the crown, which we are actually debating day by day. So some call antimalarial drug, rheumatological, and a few talk about azithromycin. So hydroxychloroquine. So whatever the standardized data we have at this moment, which is an observational study. So few things about HCQ. So we know it prevents endocytosis of a coronavirus, so block the entry. It has some immunomodulatory effect, and proposed effect given by both the studies as well as ICMR is it enhances viral clearance because it is preventing the virus to go inside, reduce the disease progression, and there are some potential side effects related to the HCQ, which made them to get this away from the solitary arm of WHO. So what they have studied, almost 1,500 patients, 811 received HCQ, standard doses, and they have seen outcome, death or intubation. So what happened? So if you see, their analysis said there is no, so if you see there is no statistical difference, so about the probability of having an event. So no significant association between hydroxychloroquine use and intubation and death. So it has not proven the test of a time. So hydroxychloroquine administration was not associated with either a greatly lowered or increased risk of composite or endpoint of intubation or death. But at the same point of time, there was one study which has actually not pointed out here. They have studied the low dose and high dose, because there is a lot of debate going on what dose we should use. And that study also said that the even high dose is not beneficial as compared to the low dose. And there is no difference between the high dose as well as low dose. But what our ICMR says about HCQ. So if you see a recent published on 22nd May, they have clearly said reduction in the infectivity and log reduction of mRNA of a COVID after utilization or using the HCQ. They said there are mild side effects reported, And what they have said is dose response relationship. So there is a definitive number of doses or a dose taken and occurrence of infection. So that means if you take more doses, which are less chances of infection. Health care workers less likely to get COVID if you are using HCQ. And All India Institute of Medical Science, the study which was almost 350 patients, there are less chance of infection who has used HCQ. So not recommended by anybody in the world. We'll come to that very concise statement related to the all bodies, but we have they have not recommended for pre as well as post exposure prophylaxis, and ICMR is recommending for the pre exposure prophylaxis. So this is the guidelines. What they have said: asymptomatic household contacts of a laboratory confirmed cases, standardized doses, day 1 400 and 400 once a week for 3 weeks. All asymptomatic healthcare workers involvement in containment, treatment of a COVID, asymptomatic healthcare workers working in a non-COVID and hospitals, non-COVID areas or COVID hospitals. So same dose, but here they have increased the duration to the 7 weeks. And asymptomatic frontline workers, you can say police, army, all those paramilitary person, they are also recommended same dose as a healthcare. And these are recent guidelines related to the ICMR. And a day back, ICMR given another update that though WHO has removed HCQ from the solidarity arms, they are pretty firm in giving HCQ for prophylaxis. Azithromycin, and we have to understand that each and every patient with the respiratory infection, we are up and right giving azithromycin. So I just wanted to clear some doubt about azithromycin. It's an adjuvant therapy, so it's not going to kill any COVID virus. Most of the time, it has been used with HCQ. There is a one small study, what they have found out, they are trying to, in adults, they are trying to find out what are the other associated infection or a bacterial infection, and they found a lot of people has a mycoplasma, so it might have a therapeutic effect related to the mycoplasma. We talk about a lot of immunomodulatory lower of azithromycin, and we know that it has some effect on Ebola and Zika. That's why we are extrapolating this knowledge to COVID. So there is no obvious clinical benefits of azithromycin in a COVID except if you have a mycoplasma infection. Fluvir, again, we have to accept that we are giving this fluvir to most of these patients, so there is no effect in a COVID-19. Other medication which they have tried, that is nitazoxanide, which is antihelminthic, arabidol. Again, I told the COVID COVID attachment to the ACE2, chemostat, mesylate, and interferon has been tried without any proper research. So what is the solidarity trial of WHO? So most of them are adults. They have a standard care arm and a therapeutic arm. In that, there are 4 arms. So HCQ alone, then you have a ritonavir with lopinavir, then you have a remdesivir, and the 4th arm, you have a ritonavir, lopinavir with interferon alpha. It's a multicentric, multinational study. Most of them are studying morbidity benefits in the form of ventilation and other extrasaturational support, mortality reduction, and in 25th, they have disarmed this HCQ because of HCQ arm because of the side effects related to the HCQ utilization. What about corticosteroids, where we should give it? And a lot of people in adults, they have started giving, and there are standard protocol related to that. But remember, it's a supportive therapy. It is not a specific therapy. Definitely, in the mild and moderate cases, it delayed viral clearance. So remember that you are not supposed to give corticosteroid in the mild and moderate cases. There are increased chances of infection and side effects. So very clearly specified in the National Institute of Health as well as CDC guidelines. It may suppress inflammatory response. That's why using methylprednisolone in cytokine storm is a little bit warranted. And we have a previous experience from SARS and MERS where there is no improvement related to the corticosteroid usage. And in influenza, when we had an influenza pandemic, it actually increased the mortality. But the study done by Willer J, which has actually tried to see the utilization of corticosteroids in ARDS. So definitely there is no role in the mild cases. But in a small study from the China, which has actually a good amount of patient, 201 patient with ARDS, it has little bit decreased the risk of a death, specifically in a severe ARDS patient. But once they specified mild, moderate, and severe, they clubbed together, they found there is not much of a difference. So at the end, I would say, after going through all the guidelines, can be considered in the most of the severe ARDS, but this is data related to the pediatric population. And definitely you can think about it if the patient is not affording in an inflammatory response. What about monoclonal antibodies? So remember again, adjuvant therapies to reduce the cytokine storm, most likely related to the interleukin 6. They are tried in adults as well as in children, because we are getting a lot of data from the UK where we see the pediatric multisystem inflammatory syndrome, potential benefits in PIMS. They have used single dose, but up to 3 doses can be used. 2 medications, we have tocilizumab and sarilumab. But remember, it increases the chances of infection because it are actually decreasing your innate immunity. So the dose is 400 milligrams or 12 milligram per kilo. Maximum 3 doses can be tried. Some of the small studies in China, they have reported, which is very small arm, almost a year, they had 20 patients. So 91% patient improved. There is a rapid effervescence of symptoms. They had a very good successful discharge. And there is a big RCT under with respect to the tocilizumab going in the China. Blood component therapy, and we see a lot of information related to the plasma therapy and IVIG. Remember about the convalescent plasma, it has shown to clear viruses because you are giving antibodies. So it's going to bind viruses and clear, as well as clear the affected cells. So you can't say like an apoptosis. It's a salvage therapy. And we have an H1N1. So a lot of this COVID experience we are taking from H1N1. But remember, this is not yet approved. And there are very, very small case reports with the good recovery. So we can't extrapolate this treatment. And there is a lot of research going related to the convalescent plasma. IVIG, definitive roles in a PIMS and a cytokine storm. And a KD-like illness, usual dose, what they have given in a small study related to the immunoglobulins at China. You can see the third one, 0.3 to 0.5 grams per kilo per day for 5 days in a COVID patient. And they have found a little bit of a better response. So at the end, if you ask me where to use, what to use, so what I did, I gone through all these guidelines and the medication. So if you see NIH, which is UK, and CDC, IDSA, pretty same. HCQ chloroquine only in trials, no prophylaxis. If you see HCQ, all the bodies has given only trials arm. So don't use upfront, except ICMR was approved pre and post exposure prophylaxis. About ritonavir and lopinavir, again, it is only related to the trials, no specific treatment. Remdesivir, what they have sent NIH document, can be tried in a severe or critical COVID. As we saw the preliminary report that it decreases the requirement of a ventilation, ECMO, and early viral load recovery. While UK has clearly said only in trials, they have not specified severe or critical. WHO again said severe or critical, you can use it. Tocilizumab, usually related to the cytokine storm in most of the studies. I could not see any guideline related to tocilizumab in ICMR. IVIG, again cytokine storm and a pediatric inflammatory multisystem syndrome. Related to that, plasma therapy, or say convalescent plasma, only in trials arm, that is not specified. And steroid, most of them said no, very clearly no, except that a small studies of a Jarvilo who said there is a little bit of improvement. What about vaccine? So if you go through the vaccine arm of a WHO, there are 10 vaccines are for the clinical evaluation, and only Serum Institute, which is actually doing a collaborative research with the Oxford University, it's going into the clinical evaluation trial. But all other 114 are pre-clinical evaluation, and we have 2 companies from India, Zydus and Bharat Biotech, which is a part of this study. You can see this is a clinical 10 vaccines for the clinical evaluation. One of them is this Bharat Biotech, Serum Institute. What happens to the immunity after infection? A lot of people have this question: does having a COVID infection gives me an immunity passport or a risk-free certificate? So it starts developing at the end of 1 to 2 weeks. It is very non-specific. If you see, there are 6 subtypes, 4 causes URTI and 2 causes bad infection. So we don't have a specific immunity related to the COVID. Then after non-specific infection, you started having adaptive immunity, which is related to the specific antibodies and cellular immunity. But what we have found out, there is a very variable levels of antibodies. So it doesn't guarantee that you will not get reinfections. No study yet to evaluate response to the reinfection. And remember, we have a very inaccurate immunodiagnostic because of the 6 subtypes. So even if we are doing IgG and IgM, we don't know what subtypes you are trying to see. So we have to do a subgroup analysis. So a clear-cut statement is infection with COVID doesn't give you immunity certificates, and still it is under investigation. So at the end of the day, the take-home message from me is, remember, it's a pandemic of knowledge as well as guidelines. Though it's a pandemic all over the world, there is a lot of knowledge and guidelines. And if you navigate through that, what I said, what I am thinking is, more I read, more I'm getting confused. They have a variable presentation in children's. Have you seen? the viral dose goes increasing into the population. We are seeing initially, we are saying there were no pediatric patients. Then we started having some respiratory patients. Then the viral load went up. Then we have the inflammatory, and probably, believe me, we will start getting more and more respiratory patients with the pediatric population. Pathophysiology is getting clear day by day. There are proven and experimental therapies available, but without a pediatric arm or a pediatric literature, there is no conclusive evidence for selective therapy at this moment, and we're still waiting for the research. So we don't have verdict till now. So we don't have a verdict for the specific treatment of COVID. But what we know it, COVID is a new normal for the doctors, and we have to navigate through it. Thank you for your kind attention. Thank you very much.
Thank you, sir, for your wonderful presentation. Now we'll go for the question answer session. The first question is for Preetham, sir. It's about N95 mask. There are three parts to this question. First is how to recognize an N95 mask by its number. What is a zero contamination mask? And third is regarding the reuse of N95 mask. If there is any study that shows that by the end of day 4, the mask was 100% virus free, and that the filtration capacity is not affected by the heat therapy.
So regarding the mask N95, it is on the mask. It would be clearly be written as to what is the certifying agency. Like it is written as NIOSH, NIOSH. Then it's a American certifying agency, and it clearly writes N95. So it says that it is a non-oil proof mask and prevents 95% of filtered particles of less than 0.3 size, 0.3 micrometer size. So that's how it is clearly written, and they would be written the company name, the 3M or whatever. If it's a European certified, it would we can write as FFP1 or FFP2. FFP1, as I showed initially, it is FFP1 would filter out 80% of particles. FFP2 is like your N95 mask, and FFP3 is more like your N99 type of mask. So it would prevent almost 99% of it. And regarding talking about the zero mask, that is a P100. What he's talking about, where it is effectively filtering out 99.997% of particles. The last question was about the how do we know whether this mask is decontaminated or not after 4 days? Yeah, majorly because they thought that SARS virus, the COVID-2 would survive for 3 to 4 days in external environment maximum. That's why that concept came about, letting the mask dry for 3-4 days and then reuse it. So that was the idea. And one study published recently, I think in NEJM, probably a month ago, it showed that there were some particles of the COVID-19 present on the mask even after 4 or 5 days. So that's when we adopted this technique of using a hot air oven of 70 degrees Celsius for 30 minutes, which would definitely kill all these particles. Yeah. Hope I've answered 3 questions.
Actually, the question was regarding any specific reference to the to these
Okay.
facts, sir. Yeah.
Okay. So regarding the reference, yes. What CDC says is, in a pandemic situation like where there is this sort of a situation where there is a limited supply, you can reuse. It also says that based on the manufacturer's guidance, suppose the manufacturer is okay and he has tried and tested it before, you can use it for more number of times also. But more importantly, what is important is make sure that the seal is intact. So on the CDC website, you can get these guidelines, whichever I've spoken about the reuse of this mask.
Thank you, sir. The next question is for Parag sir. It's about your experience with positive RT-PCR in suspected cases, and regarding the use of CT scan findings for treating COVID patients, as in adult ICUs are using CT scan findings. What is the relevance of using it in pediatrics?
I'm audible?
Yes, sir.
Okay. So about RT-PCR, so we are doing RT-PCR as a nasopharyngeal. So we have to understand two things: that the positivity of nasopharyngeal RT-PCR is around 60%. So there is a chance that either you're gonna get falsely positive and negative for almost 40% of the patient. Second thing is an antibody test. So there is a 40% of the patient which we will not able to identify whether they had a COVID or not. That's one thing. So that is always a limitation of RT-PCR related to the nasopharyngeal and oropharyngeal. Actually, if you see oropharyngeal, it is 30 to 40% positivity only. So definitely it's a pretty bad limitation related to the RT-PCR. About CT scan, so let it be, most of the patient coming into your hospital are so either in the 3 arm, probable, suspect, or at this moment confirmed. But we don't have an RT-PCR available immediately in a few hours. So we're gonna treat them like a confirmed patient. Now, most patient we are seeing in our ICU, we are not seeing any positive RT-PCR report. We have sent few patients with the ET aspirates or a BAL, still the reports are negative. There is only one patient we had an inconclusive report. So most of this patient, what we have seen who has a negative, they didn't require CT scan, but we did a CT scan in a few patients, but they had a bacterial infection. So ultimately their staphylococcus came positive or other bacteria came positive. So if you ask me, I'm not a good person to answer that question about a CT scan in this pediatric patient, but what we have seen from the adult literature and a few pediatric patients from the Europe as well as North America is definitely they are having the subpleural pathology. They are less chances of having pulmonary embolism, probably related to the endothelial injury. That is pretty clear as compared to the adults. And third thing is all the patient who went into the kind of a bad ARDS, they have a frank vasoplasia. That I can say from the literature. Surya?
Yes, sir. Yes, sir. We'll go to the next question. Yes, sir.
No, please go ahead.
Yes, sir. The next question regarding your experience in dealing with COVID, sir.
Good. So it's good and bad. Good about is that one thing we have learned over the time that every patient is positive. Just imagine every patient is positive, and stick to what Dr. Preetham has said. Stick to strict personal protective equipments. That's one thing. Second thing, I would say whatever. Again, I'm talking about probable and suspected patients. So probable and suspected patient, because I told most of them are coming negative. Most of them, I would say, mildly symptomatic. Around 50% are mildly symptomatic. I would say 30% around moderately symptomatic, and very few are coming in a bad state of a severe things. And we are following the standard respiratory protocol for the escalation of respiratory support. Most of them patient has required heated high flow. Very rarely they have required NIV, and we try not to use NIV because of a lot of other things. We know if the test come positive in a couple of days or it's taking longer time, so we are exposing the healthcare workers for the aerosols, though we are taking a PPE precautions. So 50% are mildly symptomatic, requiring low flow oxygen, and they are actually getting out of the ICU very early. 30% are moderate, and there is a 20% who are coming with a severe infection, and most of them are coming negative. So second thing is segregation of a patient depending upon the risk stratification. So risk stratification, and thing which is very important to or to maintain the flow of patient is Destratification. Destratification means the moment you had a COVID negative, get them out of the negative pressure isolation, because we have 2 negative pressure isolation and we are very judiciously using them. The moment they come negative, we get them out of the negative pressure isolation and we get the new patient there.
Okay, sir. So next question is for Preetham, sir. Regarding the three-ply face mask, is there any method to identify a genuine three-layered mask? And also, is there any specific company make which you recommend for the three-ply mask?
If you can break the mask, especially on the edges, then you can, I think I showed in one of the slide as to how to identify those 3 layers. There will be 2 non-woven layers and there will be one thicker layer, which is the melt blown layer. So melt blown layer is one which would prevent most of these particles from entering inside. So that is important. So when you, on the edges, if you just can rip off the mask a little, then you can easily look for those 3 layers. So that's how you can make it out. And there are most of these masks are made in unorganized sector. So I think few of them, Mediclin, MediBlue, are few ones which are have been supplying masks from quite some time. So probably you can buy from them.
And sir, regarding the OPD measures to prevent disinfect the OPD clinics and use of copper rooms for OPD. Is there any
Use of
recommendation like that? Copper, COPPR, copper.
copper. Okay. Copper, yeah. Copper, I think probably the interest has been because it has been found that the virus on copper is only lasting for 4 to 8 hours. So that's why I think the interest in copper has come. Otherwise, most of the surfaces like glass, plastic, it is lasting anywhere from almost 8 hours to sometimes 2-3 days also. So that's how the copper this thing has come. But again, usage as such in everyday usage of copper is very limited, isn't it? And coming to the question about what to do in OPDs. OPDs, what we are generally doing is every 1-2 hours, you wipe off all the surfaces, including your patient contact areas, your computer, your keyboard, your mouses, and including your pen and everything. Okay, of course. For every patient, you definitely put the hand wash. And important areas which sometimes get missed out are the doorknobs and the seating surfaces. So what we have done is all the mattresses, whichever the patient mattresses, we have removed the bed sheets from them. We have put a plastic cover on them and cleaning them periodically. And any, especially if you are making the child sit or lie down on them, more so children between age groups of 0 months to 1 year, we are using a disposable wrap on them so that at least it is put on and the child is put on it, examined, and the same wrap we are using when they're going to the vaccination. The same thing is taken off, and then they're on the vaccination uh, bed also. It is the same whatever wrap is used. So that's how at least you can minimize the cost and also minimize the risk of viral transmission. Hypochlorite is the key here. Hypochlorite mopping or wiping every time. There are some people who have used things like sprays, hypochlorite sprays, but they are found to be ineffective in the sense that they don't have a, you can't reach out to every area when you just spray things. It has to be cleaned. Each area has to be cleaned rather than, just sprayed.
Thank you, sir. Parag sir, can viral load be tested in COVID-19? And now that the flu season is nearby, how to deal with the situation?
Good. So yes, viral load can be checked, and if you see both studies related to ritonavir, lopinavir, and remdesivir, as well as ICMR also said the viral load, load is less after utilizing the hydroxychloroquine, so it can be checked. And remember, the moment we're going to have a lot of viral load into the community, we're going to get more and more patients. So definitely we can check the viral load by doing a PCR, or probably a blood PCR. Okay, that's one thing. Second thing is flu season. I would say it will be scary if we see COVID and flu together. And we have to try a lot of combination medication. So we really pray God that before the flu season comes, we have some medication which is actually taking some role into the COVID scenario. And the only good thing would be, I would not say good thing, but from our point of view, even if it is a flu patients coming, there is no way we will be able to differentiate between the two initial period unless and otherwise we have a PCR positive. And we know that even with the flu, we have a false positive and a false negative. So though we have a medication and there are a lot of doubt raised towards the fluvir as well as oseltamivir availability as well as efficacy. So I don't feel so it will make the things bad. The only thing I would say is we will see a little bit of more patient because there are co-infections. So probably will pretty follow the same standard of care what we are giving to the COVID patient at this moment. The only thing is the interaction between the two, how they will present together, in the sense they will be more symptomatic, more bad. We have to think about the interventional things early, like getting them on ventilator, ECMO, and all those things. We probably don't know. But I just wanted to tell you, when the COVID started, that was a flu season in China. So if you see, when the COVID started, lot of these patients got fluvir. And that is the experience of a fluvir in a COVID, that the fluvir doesn't work, or you require very high doses causing a lot of problems. And when they started giving fluvir and they saw there is no improvement in this patient, then they started realizing it is something different. And then the arm went all towards the COVID. So probably in China, if you see, a lot of this patient has been replaced by COVID rather than H1N1. But for our purpose in India, probably will follow the same protocol what we are treating with the COVID, and we might see a more sick and serious patients.
Will the dosage of fluvir will be higher in this case, sir?
No, because there is no studies or no dose equivalent studies which says that higher doses increases the clearance of flu. So the dose would remain same, which is pretty standard dose as compared to the weight as well as age.
Yes, sir. Preetham, sir, is there any recommendation regarding the usage of air conditioning during this time in OPD and in hospitals?
Yeah, primarily your AHUs have to be separate. So that's a key here. You cannot have a common AHU for 2-3 different wards, because anybody in this ward infected can pass on this infection to others. And if you are admitting somebody, let's say a suspected COVID-19 patient into a ward, then make sure that actually ideally would be a split type of air conditioner for that room itself is the best solution, because it doesn't carry the infection from there to anywhere else. So that's the best way. And having a separate IC with a separate AHU is the key here.
Sir,
AHU, sorry, is the
your
air handling unit. Yeah, air handling unit. Yeah.
Okay.
Sorry.
And sir, what is your opinion about aerosol generated by speaking and breathing? And also, when children are crying, the amount of aerosol generated will be higher. So,
Definitely.
is there any? Yes.
Definitely yes, because aerosol generation is again those droplets. Whenever you are crying or whenever you are coughing, almost causes same amount of aerosol generation. So this would be dispersed into the air. What happens generally is, whenever you are you've done that aerosolization, the particles, they gather moisture or humidity from the air and then drop down. Okay, and also with the drift of air, suppose there is a air current going on, then it carries away the particles. But whereas if it is indoors, then that is where the problem stays. So it stays for longer time. One of the things which has been mentioned, especially when you are having an air conditioner in your chamber, is to open out the windows for 15-20 minutes after you switch on the air conditioner to get a little bit of fresh air in and get this air out. So that is also going to decrease the load of virus inside the chamber.
So,
And
yeah.
sir, yes, sir.
Just one thing about what Dr. Preetham said is very important. But if you see, means like we know a lot of studies that coughing and all those things increases the aerosol. But if you go into a WHO site and see the aerosol generating procedure, they have not said cough and all those things increases the aerosolization. They have not included that, which is really bad, because we are realizing that a lot of getting infection even without they are not on any, or they are not doing any aerosol generating procedure. So definitely the infrared camera has picked up with the cough, there is a lot of aerosol generation, but WHO has not included into that. And second thing about AC, if you know, there is one kind of a standalone AC available. It's not an AC, it's basically an ionic exchanger and HEPA filter. And if you see a lot of units who don't have AHU, who don't have a HEPA filter, they started keeping this kind of a AC like unit into the room, which actually just clears the air. Air goes into that, it creates with the ionic filter and HEPA filter, and it goes off. I don't know it's doing anything, but a lot of people started utilizing. Yeah.
Yeah, that's an air purifier, basically air purifier. Yeah. It also reduces the content of particles in the air. So it is, I mean, technically they say that it does take care of the viruses and bacteria also in the air, but no studies about COVID in these sorts of situations.
And sir, how frequently to disinfect OPDs with hypochlorite?
Ideally, once in 2-3 hours, ideally. And if it is earlier than that, nothing like it. But whenever there is a patient contact, the surface ideally has to be disinfected before there is any other patient contact in the same place.
Parag sir, is there any role for anticoagulants in treatment of children with L-type lung? No
role. But so what I spoke about thromboembolism, how they identified is by doing a CT angio in adults. That's one thing. Second thing, what I talked about lupus anticoagulants, what they found, those patients who died of ARDS, they took out the lung and actually checked for the histopathology. And there actually they identified there is another pathophysiology which is going on, which is a lupus anticoagulation. But the experience from the adults, if you see any adult patient who going on ventilator and is getting bedridden, it is standard practice to start heparin, at least at the prophylactic doses. So at this moment, in adults, they are aggressively utilizing anticoagulation. But in the pediatric population, up till now, there is a very scarcity of the data related to the thromboembolism. I know few of my friends in Europe, like in Spain and Italy, they have shared couple of patients who had a small thromboembolism, which was actually identified in the CT scan rather than as clinically. So at this moment, there is no indication related to the utilization of heparin or anticoagulation in a pediatric population.
And sir, what is your opinion about why there is a low pediatric age group mortality in COVID-19, and why India as such has a low mortality with right now compared to other countries?
Good. So pediatric less involvement. So we have a three hypotheses. One is the kids have a less expression of ACE2 receptors. So what is this ACE2 receptors? This is as I told you, this is an entry of this into the nasal septum. So they are going from the respiratory epithelium to the body. So less receptors, less virus. That's one thing. Second thing is an immunity. So they are getting exposed. They have been not exposed to a lot of viruses. So they are started having some kind of a cytokine storm because of the immunoglobulin or immune dysregulation. But they don't mount like a serious response related to the COVID virus. Third thing is a BCG. So BCG stimulates lot of T cellular immunity. And remember, all viruses and fungal, the most important thing is a T cell immunity, which is going to kill the virus infected cell as well as virus. So they have a really early T cell immunity because they got a BCG in the last probably a few years or a few months. So as compared to the adults. Fourth thing is they have a less comorbid situation. So they have a less obesity. If you see, very important feature which is actually found to be related to the high mortality is less obesity. They have a less hypertension, renal diseases, and all this collectively making them less vulnerable for serious infection. And about India, so what we did in India is we promoted the lockdown. One thing, in a lockdown, remember, there are people coming outside, probably they're getting exposed and all other things. But if you remember kids, so there are kids since last 60 days that they have not came out of the house also. So their exposure to the higher viral load is less likely, because if you have a less ACE2 receptors, you really require a very high viral load to get the things inside your body. So that is the reason that we are seeing the less, and we are pretty sure about stopping these institutions, schools and all other things. That's why we are getting a less involvement of the pediatric patient. But mind it, the moment we started going into the community, definitely the viral load is going to go up, and probably that will be the I would say the test of a time where actually we might start seeing more patients, because this is not going to go away. This is going to stay there. This will be a new normal to live with corona.
Yes, sir. Preetham sir, regarding how to disinfect ourselves after a day's work in ward, many questions regarding that.
Outside.
Yeah, primarily, I think all of us, once after the work, then after you have doffed everything off, you have to shower and discard those clothes, wear a new set of clothes, come home, and once you come home, again get into a shower and put off all those clothes, whatever has been carried to the hospital, and wear a new clothes. And these clothes, whichever you have discarded, ideally to be put in the laundry immediately and washed with hot water with higher temperature, about 70 degrees or so, so that all this virus is gone. So that's one of the ways which can probably minimize the exposure at home. And second thing is all your keys, spectacles, your mobile phones. Now these are the fomites which which you carry right from hospital to home. So these are the ones which have to be specially taken care of, so that you don't carry these fomites home. So these are 2-3 things of what you can do to get rid of this virus, catching it from work to home.
Those are the questions that came in, sir. Thank you so much, Preetham sir and Parag sir, for the excellent presentation.
Thank you, Surya. I think you did a wonderful job. Thank you.
Thank you, sir.
Very much. Thanks. Good night.